I'm going to officially greet all of you. Thank you so much for joining us today. My name is Amy Bowler. I am one of the admissions team members here at Sunrise RTC. We're super excited that you've joined us and taking the time out of your busy schedules. I know that this has just been kind of a crazy time for everyone. Everyone's trying to kind of re-navigate how we do therapy. And so we're really trying to make sure that we are providing relevant content for you so that we can help you through this time. So thank you so much for joining us. As far as just some basic housekeeping rules, make sure that you do stay muted. You should automatically be muted when you join, but make sure you stay muted. We will have a question and answer period at the end after we get our training. And so I've got a member of our team monitoring the chat. So when you do have questions that come up, please type them into the chat. And then once it comes time for the question and answer, I will field those questions to our presenters. And then, like I said, we will be sending out the recording of this episode and any other related information by the end of the week. And then I will send out the link to the following episodes as well. So we'll just go ahead and introduce our presenters. I'm super excited to partner with them. This is my first time meeting them, but my team got to meet them. They came out and met with our Sunrise team in October of last year, and we are very excited to partner with the Duke University School of Medicine Cognitive Behavioral Research Program and Treatment Program. Kristen and Colleen, I hope you both don't mind, but I'm just going to say your first names because I will butcher last names. Maybe not Kristen's last name, but I am pretty sure I'd butcher Colleen's. So, yeah. Kristen is a medical instructor in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center. She has clinical research experience with both CBT and DBT and trained psychology interns in those two psychotherapies. And then Colleen is also a medical instructor in the Department of Psychiatry and Behavioral Sciences at Duke. She has clinical and research experience adapting evidence-based treatment programs for teens, young adults, and their families. And she specializes in providing individual and family-based treatment for teens and young adults with emotional dysregulation, borderline personality disorder, and PTSD. And Kristen and Colleen actually founded the DBT Young Adult Program for Duke in 2017. So, ladies, take it away. We're gonna give them an opportunity to do some training, and then we'll do some question and answers at the end.
Thank you, Amy, Brad, all of Sunrise for having us. We're delighted to be here today. And Colleen and I both love DBT and are super passionate, particularly about applying it to adolescents like the young ladies you all have at Sunrise. But I guess Colleen and I both really work with 12 and up. So we sort of do both, but we're delighted to be here today. So thanks.
And I'm doing a good job of making sure I am unmuted because we were cracking jokes before this started about like my first experiential practice is exposure to shame by continuing to forget to unmute myself in every Zoom I've been on for the past 12 weeks. So as the introduction stated, Kristen and I are both really passionate about adapting evidence-based treatments for the context in which they need to be provided. And so Lemonade Out of Lemons is this, the past 12 weeks for us at Duke has been a living in vivo practice in on-the-fly adaptation. And so we're gonna tell you a little bit about the adaptations that our program has made, how we came to some of those decisions as a DBT team, and then really jump into case examples of how we've specifically used telehealth to help with the experiential part and the skills generalization part that is so critical, not just to DBT, but to any really good CBT. We will first start with non-acceptance. That as a DBT team and as individuals on our DBT team, we spent a lot of the first couple weeks of March pretending like this wasn't going to be a big deal. So we kept trying to have DBT team around a conference table, but just sit a couple more feet apart than we used to. We thought that this was going to be temporary, so we told all of our patients, we're going to take a 2-week break from group. It's going to count towards your 4 misses, and then we'll come back to it. So we were really in this place of being sort of rigid with what we thought team needed to look like and what we thought skills training needed to look like. And we were having a hard time adapting to the current reality. Kristen, you want to talk about the opposite of non-acceptance?
Radical acceptance, all the way. So of course, like we as a team, as information continued to unfold, had to gradually shift out of this willful holding on to, I think Colleen, before we started, called it playing the DBT adherence police, which she and I are really good at. We are really dedicated to this model. And so I think initially we were really rigidly sticking to the original form of DBT and how our team has come to adherently do it. However, ultimately had to shift into using our very own DBT skills on one another and our team as a whole, and using lots of dialectics to see how we could really emphasize the function of the form that we had come to be used to and appreciate and, you know, use. To shift into how can we honor those same functions in this new context by really like emphasizing the effectively skill, thinking about our new context, assessing our new context, and figuring out what would be the most effective way to actually achieve our goals in said new context. And in particular, using really dialectics and dialectical strategies like lemonade out of lemons, or you could argue the improved skill, making meaning out of this challenging situation, to really being able to like use this context to make the most out of it and actually celebrate the great parts of it. In particular, I'm honestly a little bit biased, but I think in ways, this telehealth opportunity that has occurred despite all these really painful things that are happening to so many people across the country with coronavirus and all the changes that has inspired, in ways like this is actually one of the best things that has happened to behavior therapy, I think, in like the past 20 years.
So examples of how we had to work our own skills to come to our own place of adaptation. We wanted to be dialectical to honor both the functions of each of the modes of treatment in DBT and honor the predictability that structure offers, while at the same time being responsive to a new context and letting go of clinging onto a reality that quite simply no longer exists. In order to get there, we had to practice what we preach with our patients, which is like, quit doing the cut off your nose to spite your face thing, and instead do what works, and do that with speed, movement, and flow in order to get unstuck. Again, dialectically, we wanted to honor that each of the modes of treatment was written and developed the way it was in order to serve very particular functions according to the treatment hierarchy, and that context, it, again, will not exist for the foreseeable future. And so we had to let go of hierarchy in terms of what we thought it used to look like, and use flexibility to keep getting the same functions of each of those levels of the hierarchy, but potentially in a new, different way. Kristen, anything on that one? Like Kristen was talking about, when we're talking dialectics, we in the red book, we have all dog-eared the pages about dialectical strategies. One of the dialectical strategies is making lemonade out of lemons. And basically what that means is, like Kristen said, finding the meaning making or figuring out like what is your end goal, what is the value you're going to, and how do you do just what is needed to get you a little bit closer to that goal and to sort of make the best out of not super ideal or planned for situations. Kristen is very passionate. She actually talked herself down when we were planning this. She said that this is the best thing that has happened to behavior therapy in the millennium. And so she talked herself down to saying in the past 2 decades. But the lemonade out of lemons for us, were one of the challenges in outpatient therapy is generalization into the person's home context. This is really our opportunity to see patients in their home context, to see people in their environments with their people who they typically have difficulties with, and to be working the skills with them, opportunities for in vivo practice and opportunities for generalizing even into places and contexts where we don't, at least at Duke, we're not legally allowed to go. Kristen?
So much to say about this. I think have like 70 years, probably right about 70 years worth of research that says that generalization is the greatest weakness of all these evidence-based psychotherapy approaches. And I say 70 years because I'm thinking about exposure therapy, which is a particular evidence-based principle that is highly integrated in DBT. And before I got into DBT, I was in an exposure lab in grad school. So really time and time again, even for exposure therapy that's been around since the 1950s, even with that particular robust treatment that works super well, we still are having trouble 70 years later figuring out how to actually make those gains that we see in the treatment context generalize and stick around to actually help people. So I think in ways, us having to do telehealth and having people not being able to come to our offices right now is actually amazing to actually help with both stimulus generalization and response generalization. So stimulus generalization being the contexts that elicit particular responses from patients, and then the response context actually being like the new behavior that we're trying to shape up. So I think this is really a fantastic thing to help us target this greatest weakness that we have in these evidence-based psychotherapies.
It's also been helpful for me. I just had a session at 11 o'clock East Coast time this morning with a DBT patient who's been struggling with like hoarding and cleaning her house because she doesn't have a lot of motivation right now to do it because there's not a lot of people coming over. And so I was able to make lemonade out of lemon. She took her phone, she showed me around her disaster of a dining room table, and we practiced together grabbing a box, shoving all of the shit in a box, and putting the box in a closet on the shelf, and using that as like an in vivo practice of the like pushing away skill of like, let's put it in a box on a shelf and come back to it planfully later when we need to. So again, working these skills of dialectics and effectiveness and flexibility, this looks like a cleaner slide than the process that it took for our team to come to it. But some of the adaptations that we've had to make, which I can imagine based on the previous episodes of this series, are pretty similar to what teams are doing across the country. We've transitioned all in-person services to telehealth, with the exception of in-person crisis services, which there have been very, very few in the past 12 weeks. And really it's about like having people in person to figure out if they need to be involuntarily committed or not. We discontinued all group and transitioned all group patients to bi-weekly individual skills. This was a feat because we have 7 stage 1 groups and a graduate group. And so getting all of those folks divvied out into half of our team, because our learners were taken off service, was quite the project. Because of the difficulty, again, reassigning 70 people worth of skills and attending to the overwhelming mental health needs in North Carolina right now, we changed our contingency from the standard DBT 4-miss rule to a 3-miss rule, because with 150 people on the waiting list, we can't be sitting around for a month waiting to see if somebody wants to come back for treatment or not. We changed the entry criteria for our DBT program. We're thinking about it not just in terms of who could benefit from DBT, because certainly we all could, but who needs DBT. So we changed the criteria to a documented diagnosis of BPD or active participation in life-threatening behaviors. Again, in order to both attend to access and to be responsive to some of the new research that's coming out, that 6 months of skills training actually seems to do the trick. We changed the commitment from a 1-year commitment where you, in standard DBT, you would go through all of the skills twice to 24 weeks with a little bit more targeted which skills we are going to teach. And then we changed our consultation team to WebEx, and because of some of the privacy concerns with some of the video health platforms, we no longer video record sessions, so we discontinued showing tape on Team. Kristen, anything else on the programmatic adaptations? So now we're going to jump into case examples, and we wanted to be particularly thoughtful about the function of this webinar as about generalizability. And so we have just a few case examples about generalizability, and then we really want to open it up to Q&A and what the rest of y'all are doing in terms of how to generalize skills. So Kristen, this one's yours.
Sure. Yeah, so we just picked a couple examples since we're doing all these telehealth sessions, and Colleen and I do lots of DBT, lots of CBT. We're doing all sorts of different experiential practices, but these are just some that we picked that we thought might be particularly relevant. This is my patient. Let's call her Jessica. She's a 22-year-old who developmentally is probably actually about like 13, 14, just for context. Actually was referred to me by Colleen after doing trauma treatment. So we had been doing sort of like some stage 2 post PTSD protocol work. However, during the context of COVID, she cut for the first time. And particularly, again, given her developmental level, actually the being in her natural environment was actually really fantastic because she wasn't already in full model DBT. She wasn't already having lots of family involvement where in Colleen and my program, parents learn the skills alongside the kiddos. So none of that was in place, but because she was home, I was able to impromptu be like, hey, you're home, go get your mom. Pulled mom into session to immediately do some of that like communication about risk and assessment of risk with mom in the room, which in ways was like its own emotional exposure and was just like checking in on the emotions of each person in the room, so to speak, in the video chat, to assess that and then be able to like coach them and validate them, etc., to start modeling that for the two of them. And then also showed mom what risk assessment looks like, but then also really coached them through together, really dragging out behavior from both of them in the moment, to identify a means restriction plan and a safety plan, for mom to be involved and mom to be able to support and to like help generalization in the home beyond just the video call, right? Because like I only see them for a little less than an hour a week. So that happened for the first session, where then we came up with like a really thorough means restriction plan for them to do after we got off the video call. However, luckily we're in DBT, or at least I'm thinking from a DBT frame, right? And next week, guess what? Therapy interfering behavior. They didn't do the means restriction plan. So given that I, again, was just having a session with kiddo and she's again at home, I was like, all right, go get your mom. So we brought mom in and in the moment had them both do a double chain, which they'd never done before, because again, like we hadn't been doing family DBT, and really helping them both and teaching mom for the first time how to like label her internal experience, you know, all the pieces of a behavioral chain. And as part of that, really used that for experiential practices with coaching them each in not just communicating to me what was going on for them that got in the way of the chain, but communicating to each other. So I kept stopping them and redirecting them to like talk to each other and helping them like rephrase what they were saying to be more descriptive, use emotion words, label things as thoughts, label things as urges, so on and so forth. And then from there, even leveraged dialectical dilemmas, the family versions. So for those of you out there that don't do adolescent DBT or young adult focused, DBT, there's specific adolescent or dialectical dilemmas that show up in that age range in those families. One of them is too loose and too strict, where too loose is one extreme, too strict is the other, and this can show up in the adolescent, in the parent, in the therapist. It can show up in all different places in the system. So I really leveraged teaching them about that dialectical dilemma to help them notice how mom was being too loose on kid because she was just like so scared about what kid was going to do. And also helped everyone notice that kiddo was also being like too easy on herself, and also using the second dialectical dilemma of like not making a big deal out of this, like treating this problematic behavior of cutting for the first time too lightly and being like, oh, it's not a big deal, I'm not going to do it again, like whatever, I don't need to do the plan. Highlighting that, and then using dialectics to help each family member in the moment identify what was valid about the other one's experience, and helping them to like validate, and helping kiddo like say to mom, like, oh, I can see now that like you didn't want to bring this up just because like you're really scared that I'm going to hurt myself, and I can like see how that would be scary for you. And we got to like pull out some of those moments and coaching that direct communication. Anything else you want to add to that example, Colleen, since you also know that family?
Nope.
Nope.
Nice job. Next patient, Mary, is another patient who Kristen and I have shared. You're going to run into this a lot when you talk to me and Kristen. We are work wives and we do the same job with the same patients. So this is a 22-year-old with PTSD, polysubstance abuse, MDD, ADHD, and suicidal ideation, and some self-harm. Kristen sees Mary for individual, and I was historically seeing Mary as the skills training group leader in the group where she was. She's been engaged in full model DBT, Kristen, since end of last summer, right? Yeah. And is currently working on substance targets. Experiential adaptation, I've run into this one a lot, that I am seeing a lot more people smoking all sorts of things in my sessions. So I am seeing people juuling in sessions. I'm having to ask them, is there a cart in there, or are you just smoking? And so one of the things that we've practiced is like, taking a whiff of a cigarette is not the tip skill. That is not pace breathing. That is not the thing. So one experiential adaptation is stimulus control, with helping Molly to get rid of having access to the Juul during session, which Kristen will elaborate on, has also taken some in vivo experiential practice in urge surfing. Because it's one thing to have the Juul left in your car before you get to the skills group. It's an entirely different thing to have it on the coffee table right in front of you. It takes an entirely different set of urge surfing kinds of skills. Because Molly has been through multiple rounds of the mindfulness skill, we can start expanding and treating some of the DBT, teaching some of the DBT SUD skills in addition to the standard skills training curriculum that she's getting in her year commitment to group. So for example, the next time through mindfulness, we don't have to do the plain old states of mind that she's now at this point heard 7 times. We can do addict mind, clean mind, clear mind. And because she's not in a group where there's other people where we need to be careful about talking about target behaviors explicitly, with her, we can talk individually about how to adapt the states of mind skill to her particular target behaviors of substance use. And then this is a Kristen example, but the dragging out of skillful behavior by engaging in, let's get some concrete evidence of you engaging in the skillful behavior while I can see you on video. So we can't, again, at Duke, we have lots of rules. We can't FaceTime our patients for coaching calls to see them, you know, dumping out substances. And so this is a new Duke sanctioned way of being able to drag out skillful behavior and see people engaging in the stuff that we're advising on coaching calls while they're in individual therapy. Kristen, your turn.
Sure. So I think you've already said lots of the things, but this particular patient, so I guess why we're targeting substance stuff is because there's a history of suicidal behavior, most recently as, gosh, life-threatening behavior. I think non-suicidal cutting happened in April. There's lots of suicide stuff going on in March. Anyway, substances were a big part of that chain. So we are working on that in the service of hopefully moving toward PTSD treatment ASAP, really using like a DBT PE sort of frame. And so as part of that, we're working on cutting out substance use stuff and really practicing dialectical abstinence. And while we've gotten lots of the more intense, more problematic substance use stuff already under control prior to COVID, basically all the substances that she used really serve an experiential avoidance, emotional avoidance function that really, that's pretty much the theme of her target behaviors all around, is that they're all experiential avoidance. So this just like has the potential to generalize across lots of other target behaviors, as well as will set her up really well for PTSD treatment, particularly prolonged exposure, which is all about, you know, reducing avoidance. So as part of this, whenever she has the urge to drool during session, or sometimes she'll forget that she's trying, like working on not doing it, and we'll just be drooling during session, I'll stop her and we'll like notice what emotions are happening and label them, and then we'll practice various skills that in time, at moments that looks more like informal exposure, about like noticing the feelings and leaning into the feelings and practicing acceptance and mindfulness with the feelings. In other moments that will be more like, okay, let's use distress tolerance to tolerate these feelings and tolerate these urges, and actually do some urge surfing or some stab skill or radical acceptance. But for her in particular, given that much of the emotion regulation function is actually driven by physiological arousal, very often we'll actually leverage the physiological sensations as either like interoceptive exposure of like, let's actually make them worse and lean into them, or mindfulness of like allowing them to be there, and if they're really intolerable and getting in the way of other potential higher in the hierarchy targets, we'll use the tip skill. But very often pace breathing, even, since that is quick and doesn't require much disruption. And I have had her take her computer to the kitchen before and been like, okay, put the computer on the counter, open the freezer, let's get that ice and let's do it. And I've also done it on my end as well with her, where I'll go get my bowl of ice and we will blow bubbles together. So yeah, there's that. And I guess adding even further to what Colleen said about the DBT SUD stuff, since we're in individual skills, we have the flexibility to actually like go add on the whole module of the component of the distress tolerance module for when the crisis is addiction. So I think we did community, we're doing burning bridges this week. So yeah. I think that's all I have on Mary. Anything else that you wanted to add, Colleen? I'm mindful of time because I want to wrap up, so we definitely have questions, time for questions.
We named this one Brad on purpose.
Just for you, Brad.
I love it. I love it.
Kristen, this one's yours.
It's a similar profile to me too, it looks like. So
So this, just full disclosure, this is not a DBT patient at all. This is a long-time OCD patient with whom I'm doing exposure and response prevention with like some mindfulness and acceptance elements. But he was the only real like full-on formal exposure protocol person that I had a good example for this talk. So here we go. 25-year-old guy who has OCD, any number of obsessions, lots of scrupulosity stuff, lots of contamination stuff, and lots, you know how OCD is, it morphs. So lots of different ones, but one that's been coming up recently since he finished his finals is that his cat bit him or tried to bite him, and then so he responded in a way to try to extinguish that response. And ever since then, he's been hypersensitive and hyper attuned to his cat's responsiveness and has had a whole bunch of obsessions that he has screwed up his cat. His cat is never going to like him again. His cat hates him. The cat really like all these just worry thoughts about that their relationship is ruined forever and he's going to have to give the cat away and that means he's a horrible person and so on and so forth. So given that we're doing telehealth and he's at home with his cat, we got to actually bring the cat into the session for some in vivo exposures where he was like petting the cat and we were saying the exposure or the obsessions and the consequential thinking out loud of like, that's right, you've totally screwed up your relationship with this cat. That's right, because you pushed him away when he tried to bite you. He's never gonna hurt you. You're the worst cat owner ever. He's never gonna forgive you. All of that. And then, having him rate his emotions, noticing the suds, the intensity of the arousal, checking in on like, what are the thoughts that he's having, feeding it back to him, saying, yep, that's right, that horrible thing is gonna happen, or that horrible thing is totally true. And just having him tolerate those emotions while he sits there with the cat, and then also having him like check in and notice that like as he's petting the cat, as he's saying those horrible things, as he's doing the stuff that previously led him to believe that he screwed up the cat and ruined their relationship, that like the cat is still sitting there, the cat is purring, let's take in some of that information. So
and my example, which we don't have a slide about, of doing a formal exposure protocol, is I am doing PTSD. I'm doing a prolonged exposure protocol with a 25-year-old who was raped in her room at home. She still lives at home. And so in session 6 of doing imaginal practice, we decided to sort of up the ante and have her do the imaginal practice as we would in session, but sitting in the room where the assault happened. And so it functioned as both in vivo exposure because she's been avoiding that room in the house, and again, like amping up, increasing the intensity of the imaginal exposure to help her get more engaged in it and get more bang for her buck out of her exposure practice. It functioned very, very well to increase intensity of distress, and it helped her, again, get sort of a double whammy on attending to in vivo and imaginal exposures at the same time in a 50-minute session. So that's what we have for formal slides. I don't have the chat window up, but we're ready.
Ready for questions? Awesome. So one of the first questions that we got, and we've actually gotten it from a few different people, is what was the rationale behind the decision that you guys made as a team to discontinue group therapy and move to biweekly individual? So, I mean, it sounds like a lot of the people are saying like, hey, we're still doing group therapy over Zoom. And so they're just curious about, why did you make that decision as a team?
So I think this one is in ways pretty simple. It's out of our control. Requires some like pretty high intensity encryption and security in its platforms, just given that it's a huge institution, right? There's like levels of risk on the line that are different than smaller practices. So there's that. But I think also, even if we were allowed, we just have patients that are a really high level of disorder in a medical center population that's unlike any other place that I've worked, where I think even when the platform catches up to a place where we can do group therapy, I think we're going to have to make them significantly smaller, at the very least, just because of the degree of therapy interfering behavior that we have, because we just have really impoverished patients with like multiple levels, like just like levels of disorder, the DBT term, of just like they struggle with many more levels than just, high SES, BPD, with PTSD, with generalized anxiety. Looks really different in someone who's impoverished, has, 20 traumas with chronic sexual abuse and no money, no resources, health problems, etc.
So, and the biweekly was because with reassigning 70 individuals from group, that would be 2 clinicians full-time effort per week to just do skills training. So the biweekly was just so that we could get everybody something instead of getting some people everything.
Got it. So to go with that, before I move on to the next questions, what was the rationale behind changing the cancellation and your miss policy?
Yeah, so we are a bunch of helpers, and we're a bunch of very nice humans, and it's hard for us to be getting pressures from the context and from what we see on the news and from what we hear from our friends that there is tremendous need out there for mental health services, and to have folks who are sitting on our caseload taking up a spot and not showing up. So part of the changing the contingency was to a little bit be attentive to our need to help more people and to be responsive to our system's need for us to be able to provide the evidence-based care that we have the specialized skills to be able to provide.
Got it.
And our patients have stepped the heck up, right? If you say they have 4 misses, they will show up on the 4th session. If you say they have 3 misses, they will show up on the 3rd session. They are responding to contingencies.
Great. So the next question that we have is, how are you specifically doing chains via telehealth? Are you using the Zoom whiteboard? Are you using a whiteboard in your office? You know, do you have some other way that you're doing it?
Kristen's about to show off her whiteboard.
You might
That's
have,
how Kristen's doing it.
you might have to stop sharing your screen, Colleen, in order for us
Oh,
to.
sugar. I definitely know how to do that, right?
Yeah.
Did I do it?
Yep.
I was showing my whiteboard. I'm doing a combination of this where I'm doing it, but also I'm encouraging people to do it with me more. I think very often I tend myself to like be, I guess, too much environmental intervention where like I'm doing it for the patient and not enough consultation to the patient. So I think this is actually a great process for that, where I'm sending them worksheets and prompting them and we're doing it together. And then I'm like showing them my copy of the sheet as I'm filling it out.
Great.
Same thing. Through our medical record, we can send PDF forms. And so we had very perky, eager interns who turned the entire handouts and worksheets into individual PDFs by handout and worksheet number, and gave them all a unified labeling scheme, which was very helpful for me. So I will send out a PDF of the general worksheet 2, the chain analysis, and patient will be printed out at their home printer and be writing, and I'll say, what did you put for number 2? And then we'll compare for the chain for what they put for number 2. I don't have a whiteboard in my home office, so I've just been sending PDFs of worksheets. But like Kristen said, I'm always the one writing on the whiteboard in my office. So this has been a welcome break to have patients do some of the heavy lifting for the chains.
Yeah. So those were most of the questions. Did I miss any questions from anyone? It doesn't look like that. Any other questions that, oh wait, I've got one. Are you finding struggle with addressing challenging topics for clients that you would typically address when they are in-person one-on-one sessions?
I personally am not. I was actually reflecting on this before we had this talk today, that in ways I actually find myself feeling bolder to bring up some things and being perhaps even more irreverent than I might normally be. And I really actually enjoy being irreverent usually, but have found myself actually more bold, which I think is a good thing in most cases and is more effective, because I think I tend to err sometimes too much on fragilizing and being like accepting and validating and not enough change. Yeah, so I actually told a patient the other day, like, if you don't want to change these things, I might not be the therapist for you. And that like led to some really significant shifts in the way that we want irreverence to shift. But that's not, to that particular patient who's exquisitely emotionally sensitive, I wouldn't typically have said that. She still got really hurt and mad at me. But I actually feel in ways empowered in moments.
When it comes,
again, because Kristen and I only work as a team with each other, I saw that patient 2 hours later for individual skills training, and we happened to be in the week of mindfulness, and she had happened to have this huge rupture with her individual therapist. So we threw each of her thoughts into a circle in the states of mind when she was having a whole bunch of thoughts about how her therapist was abandoning her and leaving her, and she could never live up to her therapist's expectations. We dealt with that in vivo in a way that we couldn't have in group because that content would be inappropriate in the group.
So similar with that question, when it comes to like terms of safety, have you had to handle any suicidal crises via telehealth? And if so, what did you do?
I had a family who the day they were supposed to graduate from skills training with me, mom aborted the son's suicide attempt. He was partway through hanging himself in the bathroom, and mom was like, he's been in the bathroom for too long, and knocked on the door. The day they were supposed to graduate from skills training group, both of them called me, and just like we would in non-COVID times, I assessed safety over the phone, and I got them to take kiddo to the hospital. So it was the same as if I'd gotten this as a coaching call. My tolerance is a little bit lower because I can't see kid to actually like get like my therapist's gut about exactly how risky he is. And it's the exact same as I would assess for safety over a coaching call. Sent him to the hospital. He was admitted same day. Kristen?
Yeah, I think I'm just having a hard time coming up with specific examples just because we deal with it so much. And I think it's in ways because we're DBT therapists, we're more prepared for this transition than many other types of therapists, right, that don't typically do the phone coaching stuff. But it doesn't even cross until the question was asked, it was like, yeah, I deal with this stuff all the time. I don't think it doesn't feel that different, but I think it's just because of all the practice with phone coaching. And I would agree that with Colleen that I would say that my limits are a little bit narrower with it simply because there is like some nonverbal communication that is lost through the video platform. But otherwise I'm doing all the things that I would normally do, doing behavioral chains, doing safety plans, using my commitment strategies, using speed, movement, and flow with my dialectical strategies, balancing them out with reciprocal, then irreverent, but same old kind of stuff. I haven't had anything that has felt super different. And again, there's just been like more opportunities for in the moment means restriction, which I think actually helps like quell my anxiety even more than when they're in my office and I'm asking them to like go home and send me a message telling me when they've done it. I'm actually able to like coach them through doing it now, and they can do it now with me, bring their computer, their phone, or whatever around their apartment.
How have you bridged that gap of not having, you know, the in-person nonverbal communication that, you know, like that gut feeling that you were talking about, Colleen, when you're with them in person? How have you bridged that gap via telehealth?
Part of this is related to my in vivo shame exposure, where I don't know if my face has always looked like this when I do therapy because I've never been able to see my face. But I feel like my facial expressions are totally exaggerated, and I'm doing a lot of like thumbs up and like cheering when people are doing things that's effective. And I'm just finding like other more novel ways to, I will like get up and dance around the guest room to show somebody that I'm particularly excited. So we actually, in DBT team, we have WebEx DBT team, we did a mindfulness practice of fully participating and showing facial expressions, doing our own version of those good old like Ekman faces, where it's like everybody looks surprised, except we all just kept looking at each other and cracking up. So nobody ever looked particularly angry. So we're finding ways like with what we're doing in team and with like getting more mirroring of being able to see what we're actually doing in session to find new nonverbals based on, again, the current reality. Kristen, anything else?
I'd echo Colleen in terms of like exaggerating my responses. For the first like month of this, I was losing my voice at the end of every day because of like how much I was modulating it, trying to show enthusiasm and intensity. And I think also the other piece that I'm doing is just a lot more assessment and a lot more requiring written practices be sent to me from patients. So like more explicit dragging out of behavior that I can observe. So using just other ways of assessment to really get me some of that information that I feel that I'm lacking. In particular with anything that's life-threatening, of course. I think I might be like a little bit, of course, I'm thorough on a good day, like any day, with my risk assessment, but I think even being more thorough, more by the book, actually like thinking about the LRAMP more than I might otherwise on those days, just to make sure I'm really checking off my P's and Q's since I'm not getting some of that additional nonverbal information.
Oh, to bounce off what Kristen is saying, I don't typically see patients sitting at my computer. And so having split screen with the patient on video on one side and the LRAMP up on the other side, or I will send a link of a YouTube video so that patient and I can watch something together for an in vivo exposure, or even pulling up like my DSM, right? And looking through criteria for what actually counts as a substance use disorder. Like this is stuff that I don't typically do in my office that is really, really enhancing my assessment and my opportunity to like use multiple, like Kristen said, multiple modes that I've not ever practiced.
Great. So last question that just came up. If you have any example, Kathy's wondering, do you have any examples of innovative group mindfulness practices that might be able to be done over telehealth?
Our team, because we're not allowed to do groups, so team is our practice of group mindfulness. We've done a lot of, again, like send out the link and everybody watches the YouTube video together. We have done Kristen, we did like a mindfulness of facial expressions one. What else did we do?
We've done some gratitude ones.
Yeah.
Where it was like explicitly attending to other people on the team. But yeah, we have very limited to draw off of since we're just going on team.
Yeah.
I'll add too to what you're saying. There was a great, and we can share this, Amy, we'll be sure to share it. There was a great mindfulness and telehealth that was shared on the listserv. Many of you may have that. It's available there, but that was extremely helpful, I found, for coming up with some good ideas. And just I had a couple thoughts in regards to chains. So there's a couple ways we've done chains. If you've ever read the book, The Little Bug That Went Cuckoo, that book does a really nice job talking about cause and effect and kind of reading through all of that. There's also a YouTube video that you can get of somebody just reading that book. And so I've done that with clients and watched that together through the platform that we're using. But then also making paper chains for behavior chain, doing dominoes, setting up dominoes and knocking them over. All that really can be done through telehealth. And then just some other things that we've done in regards to life worth living. We had some of our students actually create a mural with their life worth living, and then show that to the instructor through telehealth or whoever their person was working with them. And then also with the House of DBT and being able to understand and explain their stages of treatment. I have had clients actually build and create a house out of poster board or doing things like that. So anything we can just to engage them. And some of that you'll do in session, some of that you're going to do as homework that they'll bring to the next session, that kind of thing. But those have been some more kind of hands-on experiential ways. And then the other thing, just in regards to group, when you're teaching a skill, the nice thing is, and Kristen and Colleen have pointed this so well, it's been kind of this merging of phone coaching and individual sessions. All of a sudden these worlds are colliding, which is so nice. And we can start to generalize those. I thought you articulated that really well, but really group formats have been very similar in that way, in terms of if we're doing self-soothe, we'll go grab the thing you use to self-soothe, and they go get their favorite teddy bear and bring it into session and show everybody. I mean, it's that kind of collision of worlds has been really nice. As we know, compartmentalization has been such an issue that we're trying to shift. So
I've met so many dogs over Zoom in the past 3 months. It's like everybody's self-soothe and distract and behavioral activation is their dog.
That's awesome. That would be one of my self-soothes, that's for sure. Well, thank you so much, everyone, for your participation and your time being here with us. Thank you, Kristen and Colleen, for sharing your experiences with us. I learned a lot, and I'm not even a DBT clinician. So I'm hopeful that everyone else learned as well. Yeah, thank you so much. Just as a reminder, I will send out the recording of the video, links to the slides, and last videos or the last episodes as well. We will have another episode. I do not have the official date yet, so keep an eye out for our 4th episode that will be coming soon. And again, thank you all for participating, and thank you, Kristen and Colleen and Duke.
Yeah, thank you. I think the take-home messages are do what works, like function over form, and be flexible and don't be scared to just like try stuff that you wouldn't typically try. If you're not normally a family person, just pull in the family members because they're right there. Just go for it.
Yeah.
Ditto. Thanks so much for having us. This was such a blast.
Awesome.
Thanks, y'all.
Thank you. Thank you.
Yeah, thank you very much, guys. Great job.